Welcome, everyone, to the NFOSD webinar series. My name is Ed Stever. I'm the president of the foundation, a head and neck cancer survivor, and a person with severe dysphagia. So I want to thank you for joining us this evening. I'm going to take a few minutes to talk about the foundation, a few other short items, and then I'll be turning this over to Dr. Ezra Cohen. So the mission of our organization is to advance the treatment of swallowing disorders in our lifetime and improve the quality of life for all those impacted by dysphagia, whether it's them or their caregivers or their little ones. And we do that through 4 primary pillars of support. We provide patient support, and we do that in a number of different ways, from drawing on our worldwide network of swallowing support specialists to connect patients with the right medical team that meets their needs, to online support groups, one for pediatrics, one for adults, and also 15 in-person ongoing support groups for people with dysphagia. We also offer educational opportunities like this webinar this evening. We raise awareness. June was National Dysphagia Awareness Month, and we reached about 750,000 people through our awareness campaign. Many of our sponsors and board members participated in that, and promoting promising translational research. We've funded research on stem cells, on the cost of dysphagia, and encouraging promising research by providing small grants in the $500 to $2,500 range during the year to promising researchers. You will be muted during tonight's presentation, but really the difference between a webinar and a video is you had to ask questions. So to ask a question, just click on the question mark. I think it's blue on your screen, and type in a question at any time. Elizabeth Lipton will be helping to field those and feeding them to Dr. Cohen during tonight's presentation. Next slide, please. The webinar tonight is made free of charge thanks to the generosity of an unrestricted educational grant by Bracco Diagnostics. So I just want to recognize and thank Bracco for their long-time support of the foundation. Following the webinar tonight, you will get an email. We encourage you to become a member for 2020. If you're not a member, there'll be a link in it. But it helps us do our mission. Now, I'm about to introduce Dr. Cohen. I thought, what better way to introduce Dr. Cohen than to talk a little bit about myself. So I'm going to do that for just a minute or two. Can we go to the next slide? So some of you may have seen this slide before, but this is a summary of my disease and treatment. Along the top of the slide are 6 surgeries I had. The next row are the diagnosis, the initial diagnosis in mid-2005, and the 4 recurrences I had over the next about 2.5 years. And then radiation, and then at the bottom is a whole set of chemotherapy regimens that I went through. So I want to focus on mid-2006 when I had a major salvage surgery. It was a 12-hour salvage surgery, but one of the questions that I was asked is if my tumor cells could be used to grow a cell line in the MD Anderson head and neck cancer lab. And I provided consent to that research. Now there's good news and bad news about cell lines. The bad news is they're very hard to grow. They take a lot of hand-holding. And the other news is that my cancer cells were very aggressive. So they were relatively easy to grow compared to other cells. So that happened in mid-2006. I had a few recurrences, and in late 2007, after my 4th recurrence, my primary oncologist, Dr. Merrill Keys, said, you know, you're just going to have another recurrence. And I said, well, what can we do about it? And he said, well, there's a trial taking place at the University of Chicago, and the drugs that we applied to your cell line mirror in many ways that clinical trial. And that clinical trial was clinical trial number 55913, and it was a combination of Avastin and Tarceva. And so I did that for the Avastin for about 10 months and the Tarceva for about 5 or 6 years. Now, the thing that brings me back to the webinar tonight is the principal investigator of that clinical trial at the University of Chicago was Dr. Ezra Cohen. So I also attended FASCO, the American Society of Clinical Oncologists in Chicago, and it was either 2011 or 2012. And I sat in on a presentation Dr. Cohen made to about 2,000 participants. Introduced myself. So we've met in the past. Not sure if he remembers me. We emailed a few times. But as part of my story, I hold Dr. Cohen in a very high position as part of kind of my extended medical team. So thank you for that, Dr. Cohen. Next slide, please. I really can't say enough good about Ezra Cohen. He's tied in with the University of California, San Diego University system. He's co-director of the Center for Precision Immunotherapy. And with that, I am going to turn this over to Dr. Cohen, and I hope everyone gets a lot out of this.
Thank you, Ed. I didn't know that part of the story, and I have to say it's incredibly flattering and touching. So it's amazing to be able to make a difference in that way. So I appreciate the story. I really didn't know that. It's humbling. So thank you. Today it's my pleasure to present really an overview of head and neck cancer to this audience, and I chose a purposefully provocative title to hopefully attract attendees. I think whenever there's sex and drugs involved, people tend to listen. So hopefully it did the trick. But you'll see that it is actually relevant to what we're going to talk about today. So it's not a complete non sequitur in terms of title. What? Oops, we'll try to advance the slides here. Yeah. Well, I want to start with talking about some of the myths about this disease and what we really used to think about with respect to head and neck cancer. And we used to think that it was a relatively rare disease, that it was a difficult patient population, that's difficult to treat, difficult to integrate new therapies or therapies with existing standards. And the picture that you see, of course, is what traditionally have been the risk factors for head and neck cancer, and that is smoking and alcohol. And of course, those two risk factors, as I'll talk about in a minute, are actually synergized with each other, with tobacco being the primary insult. This really represents the old world, if you will, or the way we used to think about therapy for patients with head and neck cancer. And this is a real patient. This is a patient that came to our clinic when I was at the University of Chicago. And you can read the card yourself. He had a total glossectomy to try and eradicate his cancer. And unfortunately, not only did his cancer come back, but now he was left with the inability to speak and the inability to swallow. So some of those old myths, if you will, were true back in those days, maybe more than a decade ago, certainly 2 or even 3 decades ago. But things are changing, and if we look at head and neck cancer now and its reality, we see really a different disease, or another way to look at the disease. That first of all, it is a curable malignancy. I'll show you in just a minute what I mean by that, but suffice it to say that the majority of patients will present with curable disease and will be treated with curative intent. For this audience especially, I don't need to emphasize the importance of functional outcomes in this patient population, the ability to speak, the ability to swallow, the ability to socialize. Really, if you think about a lot of what defines us as being human, it occurs above the clavicles, and both the disease and the treatment for the disease for head and neck cancer impact those functions tremendously, or can. It's also a model of carcinogen or viral-induced cancers. We'll talk about the virus in question in just a moment, but from a research perspective, it offers both of those avenues for study. Translational research is feasible because many of these patients have tumors that are easy to biopsy, and it really is an open arena for novel therapies. And towards the end of this talk, I'll talk about a major push for novel therapies with immunotherapies now going on. So this is, I would argue, the reality of head and neck cancer. This is Grant Achatz. For those of you who don't know, Grant now runs a few successful restaurants in Chicago. Some of you may have heard of a restaurant named Alinea. Back in 2007, Grant was named the best chef in the world by Bon Appetit magazine, and Alinea was named the best restaurant in the world by other publications. But shortly after that, believe it or not, he was diagnosed with oral tongue cancer, and the cancer was so extensive that he was offered a total glossectomy by several institutions. That, for many reasons, was unacceptable to him, and he sought out another way to approach this disease, and came to the University of Chicago under our care, and we treated him with chemotherapy radiation. This is Grant after several years after completion of that therapy, and now more than a decade later, he continues to remain cancer-free. He's opened up 2 more restaurants and a bar in Chicago, and continues to excel at what he's doing. And so I put him up as an example of what we are trying to do with head and neck cancer, and that is cure patients without the devastating functional outcomes that we used to see maybe 15 or 20 years ago. With respect to the disease itself, in the United States in 2019, we'll see about 65,000 new cases, about 15,000 deaths. Worldwide, it's a much bigger public health issue with about 600,000 new cases, and that's probably an underestimate. It may even be close to 1 million, because some parts of the world where this cancer is endemic don't necessarily have great incidence figures. It's the 6th leading cause of cancer mortality, and interestingly, there's a male to female ratio of about 3 to 1. Here are the 10 leading cancer types in the United States. These are 2012 data. The 2018 data haven't changed very much. And you can see that for men, there is oral cavity and pharynx at number 8. But for women, it really doesn't show up in the top 10. So again, illustrating that this is more of a male disease than female. But I would also argue that it's a disease that goes beyond the incidence in terms of its importance, and that relates back to the functional outcomes and the quality of life for long-term survivors that are inherent in both the cancer itself and the treatment, making it, I think, a much more significant entity than the pure incidence would suggest. This is a busy slide showing multiple cancers, but I'll draw your attention to oral cavity and pharynx right here, because it illustrates one of the points I was trying to make before, and that is the majority of patients will present with either localized or regional disease, and therefore would be candidates for curative intent therapy. So this truly is a disease that at least 90% of patients, when they present, will be considered for curative intent therapy. As I'll show you in just a minute, of course, we don't cure 90% of patients, unfortunately. Hopefully, we'll get there one day. But the great majority of patients will at least be considered for curative intent therapy, and I'll show you what that means in just a minute. The risk factors for the disease are age. The majority of patients are greater than 50 years old. Tobacco and alcohol that we talked about, with tobacco being the major risk factor. But now we recognize that there are 2 main viral etiologies: Epstein-Barr virus, which is responsible for some forms of nasopharynx cancer, especially endemic forms in parts of Asia, Africa, and the Mediterranean region. And then what we're seeing in this country is HPV, or human papillomavirus, and we'll talk about that a bit more extensively in just a couple of minutes. There are hereditary syndromes that have a greater risk of head and neck cancer. The prototypical, or the notorious one, is probably a better word, is Fanconi's anemia, where the incidence of head and neck cancer in those people that survive to adulthood, and now many or most children with Fanconi's anemia do get transplanted as children, so they are surviving into adulthood, and they have about a 200 to 250-fold higher chance of developing oral squamous cell carcinomas. And in fact, it is the squamous cell carcinomas that end up killing these patients in their 20s and 30s, because they no longer die of bone marrow failure or leukemia in childhood. So let's talk about sex. When I bring this up, because really we're going to talk about HPV or human papillomavirus. And what we've come to recognize is that HPV is an increasing cause of head and neck cancer, especially oropharynx cancer in this country and several countries around the world, especially Western and Northern Europe. What you can see in panel A is that, in fact, the rates of HPV-related oropharynx cancer are increasing in the United States, and it is one of the highest increasing incident cancers that we have, and the trends continue in that direction. Here you see HPV-related. And despite the fact that we do have a preventative vaccine for HPV, the rates of vaccination, these are 2010 figures, but I can tell you that the more recent figures haven't changed markedly. The rates of vaccination are really, I would say, pretty poor. And so although in the United States there is a preventative vaccine, in order for that to work, we have to use it. And the data would suggest that it's not being utilized to any great degree. And we don't expect that the incidence rates for HPV-related oropharynx cancer are really going to go down, at least not in this generation or in the near term. In fact, HPV-associated oropharynx cancer has now taken over with respect to the HPV-related cancers as the #1 cause. Here you see in terms of total patients, and again, these are 2009 figures, but the more recent figures are even more striking, that the majority or the greatest section of that pie belongs to HPV-related oropharynx cancer. It's overtaken cervical cancer, anal cancer, and vaginal cancer. And for men, it's the predominant form of HPV-related cancer, as you might guess. And the reason that this is the sex part of the talk is that HPV cancers, and that includes oropharynx cancer, is a sexually transmitted disease. This virus is acquired through primarily oral genital contact, and the epidemiologic data would now strongly suggest that specific sexual behaviors are related to the risk of developing HPV-related head and neck cancer. So with respect to HPV head and neck cancer, there's a strong association with oropharynx, especially the tonsil. This can occur in non-smokers and non-drinkers. In fact, that's how we began to recognize that there was something different going on. All of a sudden, our waiting rooms and our clinics were now being filled with patients who had oropharynx cancer that had never smoked, never drank. And we began to get curious as to why that is. These patients tend to be about a decade younger, so they can be in their 40s and 50s. Interestingly, the male to female ratio is preserved. It's still 3:1, and the specific reasons for that is not well understood, but it probably has to do with the way the male or female immune system responds to the HPV infection in the first place. And then 90% of the head and neck cases are HPV subtype 16. That's in contrast to cervical cancer, where it's about 80% HPV 16. Now, if there's a silver lining to the HPV story, this is it. It's a much better prognosis disease. And we've seen that in study after study, that when we compare HPV to non-HPV related oropharynx cancer, and even if we equilibrate for all of the other prognostic factors that we can think of or that we know of, HPV becomes actually probably the biggest driver of survival in these cohorts. So if there is a bright side to the story, that it is that there is a prognostic effect of HPV, and it appears to be a positive prognostic factor. Underlying all this is, of course, biology, and this is not meant to be read. It's really meant to demonstrate that when we look at a molecular level at the differences between HPV positive and HPV negative disease, we see some stark differences. And now we recognize that these are not only clinical entities that are different, but even at the molecular level, these are clearly different diseases with different signaling pathways and different immunologies being turned on. So we now have two distinct head and neck cancer entities, the HPV positive cancers that you see on the left and the HPV negative cancers, and they are distinct in their anatomic location, their histology, their age, the risk factors, the incidence, and of course the survival and the molecular biology. And although we don't treat these patients differently yet, we are beginning to think about how we can manage these patients, or how we should manage these patients differently, and of course are performing prospective trials to do that. So with that in mind, I think, Elizabeth, this would be a good time to begin to take some questions, if there are any from the audience.
Yes, we do have one question that came in. The first one I'll read to you here. Does this mean that Gardasil prevents oropharyngeal squamous cell carcinoma? They're asking because they were under the impression that it only prevented the strand of HPV causing cervical cancer.
Well, that's a great question, and the answer is yes. Well, let me put an asterisk on that though, and say that what we do know is that men and women who have been vaccinated with these preventative vaccines, and Gardasil is one of those, have, believe it or not, 100-fold lower incidence of having a high-risk HPV oral infection. We believe that the HPV infection is the precedent to HPV cancer. That sort of makes sense. And so if you're preventing the infection, you're almost certainly going to prevent the cancer. And it is a striking 100-fold difference. And that was published by Maura Gilson and her group in JAMA Oncology a few years ago. So in all likelihood, the preventative HPV vaccines that are currently available, including Gardasil, are going to be preventative for oropharynx cancer, as well as other HPV cancers, that cervix, anal, and penile.
We have another follow-up question here. They're wondering if the HPV vaccine is only intended for females or females and males.
It is, in fact, females and males. The CDC changed that recommendation now probably about a decade ago. And so both boys and girls should be vaccinated. Even if it's for cervical cancer, remember, how do women get HPV of the cervix? It's through sexual contact. If they have to come in contact with somebody who's carrying HPV, and most of the time that's a male, although not exclusively. So even if it's for cervical cancer, males should be vaccinated to prevent transmission. However, as I just said, in all likelihood, this prevents oropharynx, penile, and anal cancers. So again, males would inherently benefit from the preventative vaccination. In fact, about a year ago, maybe a little bit more than a year ago, the CDC and the FDA extended that recommendation to adults up to the age of 45, with the recognition that with the multivalent vaccines, remember, Gardasil doesn't only hit one subtype of HPV, but multiple subtypes, that there are likely adults who, although they may have been exposed to one or two subtypes of HPV, and incidentally, about 80% of us have been exposed to HPV, and carry antibodies against it. But most adults are not exposed to all the high-risk strains. And so the FDA felt that there was still utility in vaccinating adults up to the age of 45. So the vaccination now has been extended to both males and females and adults to the age of 45.
Is there a minimum age at which children can get vaccinated?
Yeah, it probably, so remember, again, the epidemiology of the disease is one of sexual transmission. So it really, if somebody is not sexually active, their risk of getting one of the high-risk strains is essentially zero. So we recommend vaccination prior to starting sexual activity, that is prior to exposure. Remember, these are preventative vaccines, these are not therapeutic vaccines. So once, and the way they prevent the cancer is that they prevent the infection. And so if somebody's already been infected by HPV, and again, through sexual activity, then it doesn't make sense to use the vaccine. So assuming that most preteens are not sexually active, that's usually the age of recommendation.
Awesome, thank you. Those are all the questions that we have right now. And just as a reminder to the audience, you can type in questions at any time. Excellent.
Great, thanks, Olivia. So from sex, let's talk about, oops, I gotta get back, here we go. Okay, let's talk about drugs. And what I mean by drugs is not as provocative. Really, we're talking about chemotherapy. And so this leads to how we manage patients with head and neck cancer. And for early stage disease, it's single modality, it's radiation or surgery, and we expect to cure the majority of these patients. That's stage 1, stage 2. For advanced stage disease, stage 3, stage 4A and 4B, we really are now talking about multimodality therapy, validated in clinical trials, with surgery, radiation, and chemotherapy. And unfortunately, despite the fact that these patients will be treated, remember what I said before, with curative intent, the long-term survival is only about 40 or optimistically maybe 50%. For patients with recurrent or metastatic disease, about 15% can be salvaged with either surgery or re-irradiation, and the remainder are candidates, or at least are being considered for palliative systemic therapy. And we'll talk about the developments for patients with recurrent metastatic disease towards the end of the talk. I put up this slide really to generalize the treatment approach for patients with head and neck cancer. And what the red line is meant to indicate is that patients whose tumors are in front of that red line or anterior to that red line are usually surgical candidates, primarily because we can take out those tumors and leave very good functional outcomes, or reconstruct to create good functional outcomes. For patients who are inferior or posterior to that red line, it would almost always mean taking out a vital structure that would make it very difficult for a patient to swallow or speak properly again. Now, that's not impossible, and certainly we do surgery, as I said before, for early stage larynx and oropharynx cancers, but for more advanced stages, really we usually treat those patients with primary chemotherapy radiation. And really now we have data in all of these settings, postoperatively, organ preservation, surgical sparing, and some data even in the neoadjuvant setting that suggests that in fact chemotherapy radiation does have utility. Let's talk a little bit about a couple of those trials to show you some of these data. The first in the postoperative setting, here were 2 studies, one performed in Europe by the EORTC, the other performed in North America by the RTOG. And what you can see here is that in fact, the addition of chemotherapy, in this case it was cisplatin, to radiation improved survival in both of these experiences. In fact, when investigators pooled the analysis, the most significant prognostic factors for poor outcome were extracapsular invasion of a lymph node or positive margins. And now we recognize that when those factors are present histologically, those are definitively patients who should get platinum radiation in the postoperative setting. There's a little bit more controversy for other high-risk factors, such as multiple lymph nodes, perineural invasion, lymphovascular invasion, and that varies from center to center. But there's no doubt that if we see extracapsular spread or positive margins on the pathology specimen, we would elect, all things being equal, to treat those patients with cisplatin radiation. The same is true in a sense in the organ preservation setting. Now, these are patients who, at least from the trials, would have been candidates for laryngectomy. And in order to avoid laryngectomy, these patients were randomized at least in this experience, RTOG 9111, to 3 different arms to try and avoid surgery. And without getting into the tremendous detail, what you can see is that the arm that actually fared best was the concurrent chemotherapy radiation. That's shown in yellow, suggesting that, again, cisplatin radiation given to patients in an effort for laryngeal preservation had utility not only to preserve the larynx, but also to improve survival. And so what we can say about organ preservation is that larynx preservation without compromising survival is possible. We've seen that now in multiple studies, that surgical salvage is possible after radiation. So even if primary chemotherapy radiation didn't work, these patients can still get surgery. And that in fact, distant failure is improved with the addition of chemotherapy, although distant failure does not happen very often in larynx cancer. What about surgical sparing approaches? These are patients who would be candidates for surgery, but are there data to suggest that they may benefit from chemotherapy radiation? And the answer is yes. Here's a meta-analysis performed by the group at Institut Gustave Roussy, looking at 87 randomized trials, more than 16,000 patients. And what they concluded was, in fact, again, the addition of chemotherapy, and it was primarily platinum-containing chemotherapy, led to an 8% difference in survival in these patients compared to radiation therapy alone or best local therapy alone. Now, 8% may not seem like a tremendous number, and I would argue that certainly there's room for improvement. You can see the 5-year survival in the red arm is still only 35%. But remember, we're talking about cure here. So we're talking about curing 8 to 10% more patients in these cohorts. And so when you think about it, when you think about the difference between dying of the disease and being cured of the disease, 8% actually becomes a clinically meaningful number as well. Elizabeth, let me stop there again and see if there are any questions about the standard management of patients with squamous cell carcinoma of the head and neck, and then we'll move on to some of the exciting developments that are going on with immunotherapy.
Absolutely. We have one question here, but I might need more information. The question says, what about a diagnosis of HPV-16? Would surgery or radiation be more indicated?
Yeah, so we are making efforts to address the management of HPV positive patients, primarily because of what I said before with respect to prognosis. These patients are generally regarded to have a good prognosis. And so one begins to think, well, if they're doing so well, if we're seeing 90% survival in some of these cohorts, maybe they don't need such intensive treatment that also leads to long-term morbidity and long-term toxicity. In other words, maybe we can scale back on the intensity of therapy, but preserve survival. But of course, this has to be done in a prospective manner, because the last thing you'd want to do is impact a patient's cure rate when they have a curable disease. That being said, the application of surgery, especially for HPV positive cancers, has really evolved over the last decade with the installation of robotic approaches. And these are what many people call TORS, or transoral robotic surgery. The robot, the Da Vinci robot, provides the ability to access the oropharynx in a way that does not require splitting the jaw or a more invasive procedure. And therefore now a surgeon, when obviously properly trained in the robot, can now remove these tumors with very little morbidity. And for especially early stage or smaller tumors, this has become a mainstay of therapy in HPV positive patients. Not so much for HPV negative for other reasons, but certainly for HPV positive patients. So indeed, the role of surgery in the HPV era has changed, and hopefully the management of these patients will be changed by ongoing prospective studies.
Excellent, thank you. Those are all the questions we have that have come in right now.
Great, thanks. So let's keep going, and now let's talk about rock and roll for the last portion of this webinar. And I'll show you what I mean by rock and roll in just a second. But what I'm really going to talk about is cancer immunotherapy, and I'm going to focus on that mostly to the exclusion of chemotherapy and targeted agents, and happy to take questions about standard chemotherapy and standard targeted agents. But there's so much excitement about immunotherapy in the field of head and neck cancer that I think we really should focus on that, because that is going to become, or already, not only is it now, but it is truly the future. So in the past, we had surgery, we had radiation therapy, we had chemotherapy, and you've heard me talk about it. But now we recognize that there really is a fourth pillar of cancer treatment, and that is immunotherapy, harnessing the body's own immune system to fight cancer. And we've seen that initially with diseases like melanoma and renal cell carcinoma, non-small cell lung cancer, and more recently we've seen it in squamous cell carcinoma of the head and neck. If you remember that slide I showed you a while ago about the biology of head and neck cancer, we recognize that in many patients with this disease, the immune system is perturbed in a way that has allowed the tumor to grow. And of course, that has to be true in order for cancer cells to eventually become a tumor. In fact, we've recognized in multiple studies, and here's one that I had the pleasure of taking part in, that when we look at the molecular biology head and neck cancer, we can begin to recognize that there are differences at the immune level. And here's what I mean, that there are many head and neck cancers, and I won't belabor the details of the slide, but there are many head and neck cancers where there is a fairly robust immune response, but obviously that immune response has not been vigorous enough to eliminate the cancer. So in other words, the cancer and the immune system have learned to live together in a way to cohabitate with the cancer, unfortunately, winning the battle for growth. We've come to recognize that there are cancers that are T-cell inflamed, and many head and neck cancers are indeed fall into that category. And then non-T-cell inflamed are the so-called cold tumors, and there are some head and neck cancers that fall into that category as well. In fact, when I was at the University of Chicago, we did such analysis, and what you can see is that the hot tumors are more common in HPV subtype. Again, remember, these are not only distinct etiologic and clinical entities, but molecularly different. But there are still some HPV negative tumors that are so-called hot. And in our analysis, at least, it was about 1 in 5, as opposed to about 1 in 2 in the HPV positives. Well, that sets the stage for at least the thought about immunotherapy in this disease. But why are we excited about immunotherapy? Why do we care? I'll illustrate that with these drawn, made up, or representative Kaplan-Meier curves. For a patient with advanced cancer, and that's what this red line is supposed to represent, unfortunately, we know that the disease, if we leave it to natural history, will kill the patient if they have advanced or metastatic disease. The y-axis is the percent who are alive. The x-axis represents time. For standard therapy, what we've been able to do for patients with advanced disease is we've been able to shift that median, so the average patient lives longer. But at the end of the day, when you follow these patients long term, unfortunately, they all die of their disease, or the great majority of them die of their disease. With immunotherapy, what we're beginning to see is a tail on that curve, and that's what we've called it. And what I mean by that is that although we may not have necessarily shifted the median, so the average patient may not be benefiting, at least not yet, there are patients who long-term are survivors. And we're seeing that in head and neck cancer already, where there are patients 3, 4, 5 years out after receiving immunotherapy for so-called incurable disease that now are alive and without evidence of disease. And that really is the excitement for immunotherapy. But of course, we have a long way to go. Right now, as I'll show you in just a couple of minutes, that tail on the curve for head and neck cancer is about 10 to 15%. So clearly, there's room for improvement. And of course, we're working diligently to do that. Let me illustrate this with a case, because I think this says a lot about what we can do with immunotherapy, and I think it'll be especially germane to this audience. This is a 55-year-old gentleman who was diagnosed initially with a intermediate or advanced stage, HPV positive base of tongue cancer in September 2015. He was treated with standard chemotherapy radiation in the form of cetuximab and radiation. Excuse me. He didn't want to undergo cisplatin, even though I just talked to you about platinum, because he was afraid of hearing loss. You'll see why that's relevant in just a few minutes. But he had treatment without interruption or dose reduction and tolerated it fairly well. Now, at the end of, this is a PET scan that's shown on the right, and what you see is the orange and the red that represent tumor, and we don't want to see those on PET scans. This was prior to his treatment, and the intent of treatment was to get rid of the cancer. So at about 12 weeks after therapy, what we routinely do is another PET scan, and what we expect to see then is a PET scan without any orange or red. Unfortunately, in this gentleman's case, not only did we see continued evidence of cancer, but it actually looked more extensive. So now, taking up the majority of his tongue, you can see lymph nodes, multiple lymph nodes now on both sides of his neck, and these were biopsy confirmed as squamous cell carcinoma. And so now we have a situation where curative intent therapy has failed, and the standard option for this patient is a total glossectomy and total pharyngectomy. That, of course, would render him just like that patient who presented me with the card at the beginning of this webinar. That would render him without the ability to speak, to swallow, and would completely and dramatically change his life. He felt that that was unacceptable. He did not want to undergo the surgery. And he asked his physician, his oncologist, if there were any new treatments or different ways to approach this. And fortunately, I know his oncologist quite well, and he gave me a call and said, you know, do you have anything exciting going on? And I said, well, we do have a clinical trial that seems to be showing some very nice effects early on in patients in this situation. And so we said, well, why don't you have the gentleman come down and we'll assess him. We'll talk about the clinical trial. This was the clinical trial that combined a PD-1 antibody called pembrolizumab, now called Keytruda, and an IDO inhibitor called epacadostat. And the idea was to try to invigorate the immune system to attack this cancer. Well, he was started on the trial, as you can see here, in 2016. And about a few weeks after starting, he gave me a call and he said, hey, Dr. Cohen, I think things are getting a lot worse because my pain is dramatically increased and I can't swallow anymore. I can only take liquids. I said, Ricky, hold on a sec. You know, you've only been on this for a few weeks. It's hard for me to believe that the cancer has grown this much in such a short period of time. I wonder if this is exactly what we want to see and your immune system is beginning to respond. Why don't I give you a new prescription for pain medicine, go on a liquid diet, and let's see what happens. Sure enough, about 4 weeks after that, he gave me a call and he said, Dr. Cohen, I have not used pain medicine in 4 days. I'm able to swallow now better than I have been for more than a year, and I think I just coughed up my tumor. And in fact, I think he did, because if we look at the PET scan that you're seeing in front of you, what you can see is a dramatic reduction in the PET avidity. You can see a small spot left in the base of tongue region, but much, much better than it was on that previous PET scan. And then a PET scan done 9 weeks after that, so now we're into July of 2016, there's no cancer at all. He's asymptomatic and he has no drug-related adverse effects. So he's had a complete remission. That was back in 2016. The gentleman's name is Ricky Rocket. Here you see him pictured with me in People magazine, by the way, my best cited publication ever. But he is actually the drummer for Poison. He started the band with Bret Michaels. Some of you may have heard of the band if you were around in the 80s. And he's done so well that he's been able to go on tour with the band for 2 consecutive summers. And these tours are grueling, night after night, of going from city to city. And he's been able to do it without any interruption, without any problem, and essentially living a normal life. We just saw him a few weeks ago. We're now into 2019, more than 3 years after starting therapy, and he continues to be disease-free. So this is really what immunotherapy can do. And if it can do it in one person, our challenge now is to learn how to do it in multiple people. The FDA has approved multiple chemotherapies, and including in head and neck cancer, as you can see from over the last several years, with the initial introductions back at the start of this decade, and now in 2019, we have approval for 2 immunotherapy drugs in head and neck cancer. I'll show you the data in just a minute, and of course, many more things in development. Well, the approval was based on phase 3 trials. The first trial was the so-called Checkmate 141 using a drug called nivolumab. Nivolumab was compared against investigator's choice standard of care in patients who had been refractory to a platinum-containing regimen. And what you can see here is that in the blue, the nivolumab improved survival compared to standard of care. And you can begin to see that there, in fact, is a tail on this curve. And again, it's modest. It's only about 10 to 15%. But the point is it's not zero. And the control arm is effectively zero. The same was true with that second drug I mentioned, pembrolizumab or Keytruda. Here's the Keynote 40 study. Again, the same sort of comparison, and again, a survival advantage to this agent in patients with head and neck cancer. And I'll pause for a second to remind us that what we're doing here is a single agent that interferes with a single synapse in the immune system and has such a dramatic effect in these patients. So the effect can be profound, especially if patients' tumors express PD-L1. Without getting too much into the biology, PD-L1 is inherently tied to the mechanism of these drugs. That's where the interference comes in. That's the synapse. And in tumors that express PD-L1, at even low levels, there's an even more dramatic improvement in survival. And in those that express at a high level, you can see that about 50% are alive at 1 year. This is the so-called TPS greater than or equal to 50%. And so PD-L1 expression actually becomes a predictive biomarker for benefit. That's also true for response rate. Most of the responders were in tumors that expressed PD-L1. And here's what I was talking about before in terms of the dramatic benefit. Because when patients respond to these drugs, the duration of response is nothing short of remarkable. The median duration of response with pembrolizumab was 1.5 years, as opposed to with chemotherapy, it's short of 6 months at about 5 months. And so in patients who do respond, again, they can have a dramatic and prolonged benefit to these drugs. Now, more recently, we've taken this same drug called pembrolizumab into the first line. So these are patients who have recurrent metastatic disease, but have never been treated for recurrent metastatic disease. And here you see the 3-arm trial of pembrolizumab alone, pembrolizumab with chemotherapy, compared to a triplet chemotherapy regimen that's been the standard of care for over 10 years. First one, looking at pembrolizumab alone, what we can see again is an improvement in survival with pembrolizumab versus the so-called extreme regimen, especially in patients whose tumors express PD-L1. This is the CPS greater than 20 population that you see at the top. Even if patients' tumors express low levels of PD-L1, as long as it's not 0, there still is a survival benefit with pembrolizumab alone. And remember, we're talking about a single drug that interferes with a single synapse in the immune system, beating out a triplet chemotherapy regimen that had been the standard of care for over a decade. And again, illustrating this duration of response, what you see in the green, the median duration of response, almost 2 years with pembrolizumab in the first line, as opposed to about 4 months with chemotherapy. Now, there are side effects to immunotherapy. As a single agent, pembrolizumab is much better tolerated, as you can imagine, than the triplet chemotherapy regimen, but it is not without toxicity. And what we see is a different toxicity profile with immunotherapy. As you might guess, we see immune-related adverse events. And for head and neck cancer patients, the most common one that we see is hypothyroidism, probably because the thyroid has already been sensitized because it's in the radiation field for the great majority of these patients. And I think that sets up the potential for autoimmune thyroiditis, and that's exactly what we see in the clinic. Almost 20% of patients developing hypothyroidism when exposed to this agent. When looking at the second experimental arm, that is pembrolizumab with chemotherapy, we again see a benefit to pembrolizumab added to chemotherapy, but here we see it irrespective of PD-L1 expression. We see a response rate that is equivalent to the chemotherapy regimen. We do see now toxicity being higher, as you might guess, because now chemotherapy is being combined with pembrolizumab, and we do see this emergence of immune-related adverse events, just as we saw with pembrolizumab alone, especially hypothyroidism. In fact, the Society for Immunotherapy of Cancer put out a consensus statement on the use of immunotherapy for the treatment of head and neck cancers, and what you can see is I'll summarize this quickly. What you can see is that for patients who have not been exposed to any type of treatment for recurrent metastatic disease, pembrolizumab, either alone or with chemotherapy, is now considered the standard of care, or a clinical trial if it's available. For patients who, for whatever reason, were treated with a platinum-containing regimen but not with immunotherapy, now single agent, either pembrolizumab or nivolumab, is considered the standard of care. But of course, if there's a clinical trial available, that would be advantageous. Now, I began the talk by saying that most of these patients, most of our patients with head and neck cancer, will present with local, regional, or regional disease, and that this is a curative, or many of the patients will be treated with curative intent. And so if we're going to really change the natural history with immunotherapy, we should begin to think about doing that in the upfront setting, in the locally advanced setting. And in fact, when we look at the biology of radiation and what it does to the immune system, there's a lot of positive things. radiation increases expression of antigens on the tumor surface. It increases PD-L1 expression, and it can liberate antigens for presentation to the immune system. So these are all positive things, and we began to recognize in preclinical models that, in fact, maybe flying against older dogma, radiation and immunotherapy have a lot of positive interactions. And as you might guess, this is now tested in clinical trials. Here's one such study that combined pembrolizumab with chemotherapy radiation in locally advanced head and neck cancer to test the safety of adding this drug to standard chemotherapy radiation. Here you see the study design, the blue bars representing pembrolizumab or Keytruda. And what we saw in this study was that it can be done really without an increase in toxicity. We saw very typical rates of dysphagia and mucositis. This would be exactly what we'd expect to see with chemotherapy radiation alone. We saw typical rates of neutropenia, again, what we see from chemotherapy and radiation, and electrolyte disturbances. And so there was no indication at all that the addition of pembrolizumab affected our ability to deliver curative intent chemotherapy radiation or increase the toxicity of chemotherapy radiation. Well, with safety in hand, of course, you can imagine that now phase 3 trials have been undertaken, and this is one such study that has been completed with a drug called avelumab, working on the same mechanism of PD-1, PD-L1 inhibition. You can see that the control arm is cisplatin radiation, and the experimental arm is now avelumab started in a lead-in phase, followed by the addition during chemotherapy radiation, and then a maintenance phase for a year of avelumab after the completion of radiation. This is in a very high-risk population. The study has been completed, and we hope to optimistically get a readout in 2020 and hopefully change the standard of care once again for patients with head and neck cancer. So I'll leave you with a few thoughts and leave some more time for questions. That most patients with head and neck cancer are being treated with curative intent, and that really leads to the importance that functional outcomes play in this disease. In fact, along with the ability to cure the disease, functional outcomes are paramount and important to both the patients and treating physicians. We talked a lot about HPV and the HPV epidemic. Unfortunately, it doesn't appear that it will abate for at least a generation based on vaccination rates in this country. And there really is an immediate need for therapeutic advances, especially the idea of perhaps de-intensifying therapy for HPV-mediated head and neck cancer. We talked about immunotherapy, mostly in the form of anti-PD-1 therapies, and they now have an established role in recurrent metastatic head and neck cancer. With current studies evaluating immunotherapy in earlier stages of disease, I showed you the avelumab trial, in combination with other immune modulators, and there are many, many studies going on doing that, and in the context of standard chemotherapy and radiation. And so with that in mind, that brings me to the end of the slide deck, and again, happy to take any more questions.
Dr. Cohen, thank you so much for that presentation. We've had a lot of questions, a lot of comments come in. I want to start with just a lot of the comments that are talking about how remarkable that case study was that you presented, in addition to all of the research. How wonderful. How neat to see that presented. I'll start with a few questions here. The first one I'll read to you here. Do you promote the HPV vaccine, and is it safe, or are there risks to that vaccine?
So the answer is yes. Promote it at every opportunity I get. From now, literally hundreds of thousands of people being vaccinated around the world, the vaccine appears to be incredibly safe. It's not that there aren't cases of patients having intercurrent illnesses that have been related to the vaccine. That is true. And if you read the label of the vaccine, it will say that there is a chance for some autoimmune reactions. But it appears that those chances are very, very low, probably talking somewhere in the range of less than 1 in 100,000 patients. And certainly when we're talking about a vaccine that can prevent cancer, I think the trade-off between benefits and risk far outweighs benefits. And so I would definitely promote the HPV vaccine.
Excellent. My next question here for you. In your experience, is there any difference in long-term swallowing outcomes for patients with HPV positive head and neck cancer compared to those with non-HPV head and neck cancer in terms of their chemo and radiation?
Yeah, so the answer is no. It's interesting as we begin to enter the immunotherapy era that there may be some differences. I'll get to that in just a second. But for HPV positive versus HPV negative patients treated in the same way, so with chemotherapy, radiation, the long-term outcomes, depending on obviously tumor site, appear to be very similar. It's just that for the HPV positives, because they have such a good prognosis, we wonder if we can scale back on therapy and improve their long-term outcomes, de-intensify, in other words. It's interesting, for immunotherapy, there might be a difference. And what we're seeing with immunotherapy is that the HPV positive patients have a higher rate of false positive PET scans, indicating that they may have a higher inflammatory response to immunotherapies. And now, especially the speech and language pathologists in our group have been recognizing for over a year that patients who are on these immunotherapy radiation studies may take longer to recover their function, especially their swallowing function, because they have more edema following radiation. It's not that they don't recover, they eventually do, but it can take many more months to do so. And so as we enter the immunotherapy era, and hopefully we do change the standard of care and improve outcome with immunotherapy, we may also be altering the recovery after radiation or after chemotherapy radiation. So something to keep in mind.
Along those lines, immunotherapy, is that available only where you work? Is that available nationwide?
So nationwide, so the drugs that I was talking about, pembrolizumab and nivolumab, are now FDA approved for recurrent metastatic disease. They're not yet approved for locally advanced disease, but they are available. They're approved, and they're widely used.
Excellent. This next question here, someone says that they have heard that cancer cells are always present in the body, but they only become cancer when they grow into a tumor. Is there truth to this? And if so, does the immune system usually kill cancer cells naturally?
So yes and yes. It's a complicated question. So let's break it down. So we consider cancer, the definition of cancer, at least pathologically, is that they are abnormal cells, abnormal looking under a microscope, that invades through the natural barrier that is present in tissues. So for mucosal cancers, that would be invasion through what's called the basement membrane and into the deeper tissues. Those cells are not supposed to be there. One of the abilities of cancer is this invasive property, and that's how we define cancer. That's what, when a pathologist looks under the microscope, that's what differentiates dysplasia or abnormal looking cells from outright cancer, is this ability to invade. Now, so that by definition, cancer really is a cellular disease. It's made up of cells that have mutations. Those mutations give those cells an ability to invade, to grow, to metastasize, etc. Now, when you have literally millions of those cells, along with their supporting infrastructure, their supporting stroma, the tumor microenvironment, you form a tumor. And actually, if you look at a tumor under the microscope, for many tumors and many head and neck cancers, it's not all cancer cells. In fact, the tumor is composed mostly of these supporting cells, these blood vessels, the fibroblasts, the immune cells, the macrophages, etc. Those make up more cells in the tumor than the actual cancer cells. But it's interesting when we begin to look at, quote, normal looking cells. And what's scary is that if I were to biopsy most of the audience skin, normal looking skin, doesn't, looks perfectly healthy. If you're above 30 years old, certainly if you're above 50 years old, if I were to biopsy your skin, those normal cells would have mutations, and they'd have a lot of mutations. And that's scary in a way, because those mutations are the same mutations that occur in cancer. So obviously, our immune system is constantly monitoring the system and eliminating most of the cells that would eventually become a cancer. So that's why the answer to the second part of that question is yes, that the immune system does prevent these cancer cells from turning into tumors, but it's not foolproof. And obviously, if it was, I wouldn't have a job. I wouldn't be an oncologist. But people do develop cancers. They do develop tumors, and we're beginning to understand exactly how that interplay happens and how cancers can actually avoid that immune. Not only avoid the immune elimination, but begin to usurp elements of the immune system to help them grow. And what immunotherapy is trying to do is reverse that process so that now the immune system can begin to do what it was designed to do, and that is eliminate cells that are different. I hope that answers the question.
Thank you. The next question here is, how do costs of immunotherapy compare to the other modalities, and does insurance cover that?
So insurance does cover it, again, because these are FDA approved, but they're not cheap. So for instance, a month of be it pembrolizumab or nivolumab is anywhere from $13,000 to $15,000. And for patients who are benefiting, you're talking about patients who may be on for a year, 2 years, some patients maybe even longer. So these are not inexpensive drugs for sure. My hope is that the cost will begin to reduce eventually. That we'll find other ways to stimulate the immune system that might not be as expensive. But for a year of pembrolizumab, for instance, you're probably looking at somewhere in the range of $120,000, $140,000.
Well, another question here, if you have time for this one. When considering TORS as a potential single treatment modality, what percentage of patients also have post-op radiation?
Yeah, and so that's a key element when we think about TORS, and really in our minds the best patient for TORS, and that's the transoral robotic surgery, so this minimally invasive surgery that can take out the cancer because the robot articulates in a way that the human hand can't. When we think about it, the ideal patient really is one that can be treated with TORS alone, so a small tumor without lymph nodes or with very minimal lymph node involvement. The second best patient is a patient where we can excise the cancer with TORS. The advantage there is that you would the patient leaves the hospital in 1 or 2 days, so it's truly minimally invasive surgery with very few morbidities. But there are pathological elements in that specimen that would necessitate adjuvant therapy in the form of radiation. Ideally, again, you'd use TORS as a single modality. If you used it and then discovered some pathological features that necessitate radiation, I still think that that's a patient that we're helping, because we're using 2 modalities. One of those modalities is pretty has pretty low morbidity. The other modality, of course, is radiation in an effort to prevent recurrence. I think candidates who aren't so good for TORS are ones where obviously you're going to need chemotherapy radiation afterwards. And if you're going to need chemotherapy radiation anyway, then the question to me becomes, well, why are you doing the TORS? You're not saving the patient anything, and because you're going to need to use the adjuvant chemotherapy radiation. So why not just treat them with chemotherapy radiation up front? And then if there's a problem down the road, well, then we might consider surgery. So so I hope that answers the question. There certainly is a role for TORS, but we have to be careful about which patients we select.
I'm going to ask one more question, and then I will turn this back over here to Ed. My last question here for you is immunotherapy an option for patients with severe dysplasia, or are the side effects too morbid? So
we're studying that right now. So just to give the audience some background, severe dysplasia is a high-risk lesion to develop cancer. Mild or moderate dysplasia often will reverse on its own. We don't really worry too much about those, but once you get into severe dysplasia, we recognize that those are lesions that have more molecular abnormalities and that they do have a high risk of transformation. Now, let's put it into perspective. That lifetime risk is only about 10%. So we're not talking about a certainty that these lesions will progress, but certainly it puts patients at higher risk. And we're looking at that right now. There are preclinical data that would suggest that immunotherapy can reverse severe dysplasia and in a sense cure these preneoplastic lesions. And we're looking at that in people with different immunotherapies right now.
I want to read one comment that just came in. It says, every person living with cancer should have such a brilliant oncologist like Dr. Cohen. And with that, Dr. Cohen, I want to thank you so much for.
I think that was I think my mother's tuning in. Thank you.
Thank you. I'm going to take the screen back from you here.
Dr. Cohen, I have a question for you.
Yeah.
And that is, you showed a map of the U.S. and poor vaccination rates. Are you aware of any best practices for increasing vaccination rates or people working on that?
Yeah, I think the best practice is universal vaccination, and many countries around the world have adopted that. Australia, Taiwan, most countries in Scandinavia, and what they are going to see, Canada, what they are going to see in the next generation is an elimination of HPV-related oropharynx cancer, cervical cancer, and HPV-related penile and anal cancers. Those diseases will no longer happen in those countries. Unfortunately, that they will continue to happen in the United States. I think for the U.S. right now, barring any federal action to instill or to start, or state action for that matter, to have universal vaccination, I think it's awareness, especially at the pediatrician level, at the parent level, at the school level, that these are not only safe, but they're incredibly effective vaccines that truly, truly save lives.
Thank you for that. And thank you for sharing all the new immunotherapy drugs that are shining a light at the end of the tunnel. I also want to thank you for volunteering your time tonight. You've joined our 100 plus participant club, and that's the club where more than 100 participants stayed for the entire webinar. So congratulations. So that's a pretty high bar for us.
Thank you.
You're welcome. So I want to thank everyone that attended this evening. If you had a question that wasn't answered, please email us at info@nfosd.com. And within an hour, you'll get an email, and in the email will be a link to a survey. We're always looking for feedback, good, bad, ugly, and the survey literally takes 2 minutes or less to complete. So that's an ask we have of you. We hope that you benefited from tonight's webinar. I know I did, and again, I want to thank Dr. Cohen for his time this evening. And with that, we'll sign off. Thank you, everyone.
Thanks, my pleasure.